Guys, so let's go ahead and let's start talking about the hip and groin, start talking about some medical screening stuff, some imaging stuff, and we'll kind of power through this. So what we're going to cover today is we're going to cover some red flags, we're going to cover some causes of hip, groin, and thigh pain, some really good physician referral guidelines like, hey, what do I do when I need to send that person out? And then we're going to get into the imaging stuff. So red flags that are associated with lower extremity, I cannot emphasize this enough. Past medical history is so important. Does that person have a history of cancer? Remember what we've talked about all along throughout this course. Predictor of cancer is a history of cancer, right? That's the number one predictor. Does that person have kidney disease or urologic disease? Does that person have infectious or inflammatory disease? Are there gynecologic conditions or considerations? Heart disease, AIDS, HIV, hematologic disease. There's a lot of different red flags associated with lower extremity. What I want you to think about is start thinking about all those structures, right? All those structures, all those vascular structures, neurologic structures, lymphatic structures, we have a ton of stuff in that lower extremity. So all of that or any of that can be the source of some sort of pathology. So when it comes to systemic causes of buttock pain, right? Exclusively buttock pain. Big one to watch out here for is secondary sciatica. Now, what is that? Well, here's the problem. It is sciatica. It looks like sciatica. It acts like sciatica. It presents like sciatica. It tests like sciatica. When you do all of your tests, you're going to think that's sciatica because it is. Understand that sciatica is a symptom, right? So what we have to kind of look at, especially with secondary sciatica, is that sciatica is coming from something else, either an infection, a tumor, something else. Okay, so be very, very careful with that sciatica. Don't stop and say, well, that person has sciatica. Well, we already knew that. Try to figure out why they have sciatica, whether that is a disc pathology, whether that's a facet joint pathology, nerve, mobility or nerve gliding problem, something like that. So, or some other sort of pathology. Other systemic causes, neoplasms, osteomyelitis, obviously, if that occurs around either the ischial tuberosity or the ischial spine. Septic arthritis is a big one. Ischemia, abscesses, right? All really, really big causes of buttock pain. Now, your NMSK, aka your neuromusculoskeletal causes of buttock pain, primary sciatica, right? Now, what is that? Well, that sciatica is just sciatica, right? It means I just have something wrong with my sciatic nerve. You still need to dig into that, but I don't have some underlying big systemic pathology causing the symptoms. Hip joint disease can cause buttock pain, right? So I can have some referred pain to the buttock if I have something like hip osteoarthritis, Legg-Calve-Perthes Disease, Ewing sarcoma, things like that. Obviously, because of referral patterns, disc disease can cause some buttock pain, and we're actually going to see this quite commonly. Bursitis, whether it's a gluteal bursitis or psoas bursitis or something of that nature, or trigger points. So when it comes to the hip, again, lots of different systemic causes, lots of different neuromusculoskeletal causes, right? So systemic causes, lots of things here, right? So we could have something oncologic in nature. We could have something vascular. We could have something urogenital. We could have something metabolic, infectious, right? There's a lot of different stuff that can cause hip pain. The big thing here, like we said all along, associated signs and symptoms is going to be the key, right? So if that person's coming to me and says, man, my hip is really, really bothering me, and they're running a 102-degree fever and they don't feel good, they might have an infection, right? Now, where does this become a really big issue? Sometimes in our total joint population or sometimes in our postoperative population. Like I've said in the past, my number one goal for my patients after surgery is not getting an infection. then my number 2, 3, 4, 5 goals are all PT related. But I do not want them getting an infection after surgery. For neuromusculoskeletal causes of hip pain, all the usual suspects are here, right? Everything from osteoarthritis, muscle impairment, stress injuries, it could be a nerve entrapment, a joint dysfunction. We're going to get into SCFE, which stands for a slipped capital femoral epiphysis. We'll get into a little bit of osteitis pubis and what those look like at images, but we're going to get to those a little later. So when it comes to groin pain, watch out for groin pain. There's a lot of stuff. There's a lot of anatomy there, right? There's a lot of structures. And they all can kind of, I'm not going to say act the same or present the same, but what they can do is they all can cause problems, right? So again, systemic causes of groin pain, cancer, UTI is a big one, right? That's a really, really big one. Understand what the associated signs and symptoms of UTI are. Peritoneal swelling is a big one too. AAAs, we're going to see those every once in a while, not very often. Infections, prostate problems, right? Those are all systemic causes of groin pain. When it comes to NMSK causes, lots of different stuff here, right? Everything from SIJ to bursitis to stress injuries to nerve compressions. There's a lot of different stuff happening here. So what we really have to do when it comes to the hip, you have to be a very good problem solver. So that's the big thing that I hope you take away from this entire course is you're going to have to kind of dig in and figure out why this person's having all this pain, why they're having all these problems. And then the other big thing is pattern recognition, right? And we've talked about pattern recognition a bunch. Those associated signs and symptoms are huge. Remember, lots of things can cause hip pain, but hip pain with a fever, with malaise, with decreased range of motion, with swelling, okay, that could be infection, right? So we have extra information and extra information and extra information that fits a pattern, right? If you can recognize those clinical patterns, then you're going to be a very good diagnostician. When it comes to lumbar involvement in hip pain, this one gets sticky a lot of times. Remember that the L5 nerve root is going to throw off a small branch over to the lateral hip. So we can see some lumbar involvement here in terms of a patient has compression fracture, radiculopathy, degenerative disc disease, a spondylolisthesis. There's a lot of different stuff happening here. All right, so big one. We've covered this one. I'm not going to spend a ton of time on it. The appendix can refer to the hip. It's mostly going to refer to the medial hip. Okay, that's a big point to remember. It's probably not going to refer out to the lateral hip. It's probably going to refer to the medial hip, more the groin. Big thing with appendicitis is that rebound tenderness. Remember, when I push in on McBurney's point, my patient has relief in pain, take my fingers away, holy cow, that hurts really, really bad. That's going to be a clinical indication of appendicitis. Psoas muscle abscesses actually happen more than what you think. And I've been surprised on some of these psoas muscle abscesses I've seen in my career. Typically, associated signs and symptoms are going to guide you here. If that patient comes in and they're not feeling good, right? They got malaise, I'm just feeling under the weather, not feeling so hot, fever, if they have some sort of lateral lumbar or abdominal pain, if they walk in and they have an externally rotated hip. Now, I'm not saying that every patient that walks in with an externally rotated hip automatically has a psoas muscle abscess. What I'm saying is the patient walks in with an externally rotated hip and they have a fever and they have malaise and they have weight loss. Okay, that's now getting into a clinical pattern, right? So that's that pattern recognition that we really need to be good about. Feeling of fullness is another big one. If they just feel like there's something really big and swollen in there, well, that's because there is, right? And we need to recognize that. Septic discs are a big one too. These get missed quite a bit. So if my patient has an infected or a septic disc, fever, chills, sweats, right? Those are all big, big things, right? So we need to recognize those. We need to understand those. So if they have something like intractable lower back pain, if they have radiation to hip, the groin. The big thing with septic ascites, and this is what we need to understand, I've said oftentimes throughout this course that movement will define an MSK problem versus a non-MSK problem, right? If that person has movements that make their pain better, movements that make their pain worse, whatever it is. The issue is for something like this, we are going to have some aggravating movements, right? A lot of things are going to aggravate it actually because everything's kind of grinding on that infected disc. Eases, nothing. And they have fever, and they have the chills, and they have sweats, right? Remember, if we see fever, we're thinking infection. So if I see that clinical pattern, then this person potentially has a septic disc. Ankylosing spondylitis, we've covered quite a bit so far. Big thing with ankylosing spondylitis, like I said, it's slow and progressive. They're going to have significant loss of spinal mobility. Remember that we're going to use that modified New York criteria, which again presents a clinical pattern. And remember that if that person has pain at rest, but they get up and move around, they feel okay, and they just kind of feel like they always have to move, then that's going to be a sign that we may be dealing with ankylosing spondylitis, along with some other signs as well. Remember, take a look at that modified New York criteria for the clues. Avascular necrosis is a big one. And I can't tell you how many times I've seen this one, both in hip fracture patients. Go back to your anatomy and go back to that drawing that we did of the blood supply in and around the hip and in and around the femoral head. Remember that those vessels can get ruptured or they can get occluded, and I could have a potential avascular situation on my hands. If I'm suspecting avascular necrosis, what we're typically going to see is really bad groin pain, really bad anterior thigh pain. Typically, there's an insidious onset of pain. And, I remember actually my last clinic job, I was treating this, I was evaluating this patient, didn't actually treat him, and came in, guy was literally dragging his right leg behind him, and laid him down, did some passive range that didn't fire him up too bad, but didn't feel so good. Guy had horrible groin pain, horrible anterior thigh pain, couldn't put any weight on his leg. Guy couldn't even think about doing a single leg stance. Asked him to do a straight leg raise. Holy cow, that threw him through the roof. I mean, it was just terrible. So I asked our nurse practitioner, I said, I think this person maybe needs to get a radiograph. And, unfortunately, we kind of went back and forth. Nurse practitioner did not necessarily want to initially do a radiograph, wanted to try PT first. And I said, look, PT is just not appropriate for this person. So we went back and forth a little bit. And what I will say is that radiograph was finally ordered. Avascular necrosis was finally diagnosis. So we ended up getting that person the help that they needed, which is the end goal. But what I will say is that sometimes you kind of have to advocate for your patient, right? Sometimes you have to advocate and say, hey, look, this PT I don't think is going to be the best option for this person. And that's okay to say that. Acetabular fractures are a big one, right? And we're going to see this one with a lot of high impact. We're going to see this sometimes in our elderly population. If they slip and they fall, if they slip on the ice or something like that. Sometimes they don't fracture the actual hip or the femoral head. Sometimes the femoral head just goes straight through the acetabulum, and that's a problem. So with acetabular fractures, we're going to have near constant or constant pain in the groin or the thigh region. And then again, a lot like our avascular necrosis, a lot like our other hip pathologies, acute inability to bear weight through the pelvis and the affected limb, right? So if someone cannot bear weight through their affected limb, we need to really be skeptical and careful about what could be going on with that person. So here's a case for you guys. Like I said, this is a 56-year-old factory worker. Here's what we got. Okay, subacute right hip pain. His diagnosis was hip OA, right? And this was the case that I had. in my last clinic job. I worked in a large industrial setting. So that was my last clinic. So checked out his hip. Didn't really have any capsular hip restrictions. Yeah, his gait was terrible. Like I said, it was dragging his leg behind him. He had a positive straight leg raise. He couldn't actively flex his hip. Felt all over the place, all around the hip, all around the groin, got nothing, and was not point tender at the greater trochanter. So really and truly, like I said before, his signs and symptoms were not consistent with hip OA, right? Hip OA should not have those sorts of signs and symptoms. What did I do next? Advocated for my patient, got him a radiograph, and found out that he did in fact have avascular necrosis. All right, so here's another case. So we got this kid's on the skateboard, kid falls off skateboard, falls on both feet and immediately grabs his groin. Holy cow, that hurts. So 2 weeks later, kid comes into your office and he has this traumatic left groin pain. We ask him all sorts of questions. You have saddle anesthesia. We give him all the red flag stuff. Nothing, right? Everything's great, except for his horrible groin pain, right? Physical exam, kid has a terribly antalgic gait. He can't really squat because it hurts too bad. Can't really heel toe walk because it hurts too bad. Tenderness around the inner thigh. Range of motion was limited. And he didn't have that, oh, by the way statement. For example, oh, by the way, I got shot out of a cannon or something like that, right? Something ridiculous. A lot of folks will say this, oh, by the way, I don't know if this matters, but, and then give you a key piece of information. So here's what we did. All right. So with this 13-year-old skateboarder, sent him in, got some radiographs, and this individual had a slipped capital femoral epiphysis. And this is a big deal because think about what an epiphyseal plate is. It's a growth plate, right? So literally, the growth plate of the femoral head has been shifted, and that's a big, big deal. So, unfortunately, the person went in, did a radiograph on him, not approved for PT at that time at all, needed some intervention other than us. So when it comes to anterior thigh, what we have to understand is that we're going to have systemic causes. We're going to have some neuromusculoskeletal causes. Anterior thigh, we're going to see thromboses, hematomas, right? Those are actually not necessarily quite common, but in terms of the pathology world, they're a little more common than others. Kidney stones or urethral stones can refer to anterior thigh. It's not normal, it's not typical, but it can happen. A retroperitoneal or intra-abdominal mass sometimes can. Again, that's going to go kind of down the lumbar plexus, if you guys remember that. When it comes to MSK stuff, all sorts of stuff can cause anterior thigh pain. Quad strains, hip problems, stress injuries, right? Contusions, bursitis. This is one I will say watch out for with MVAs. Like there's a lot of folks that their anterior thighs will hit the steering wheel, right? Or they'll get kind of bounced around inside the car and they'll end up having anterior thigh pain. So just kind of watch out for this. All right, so here's another case. What we got is we got a 38-year-old left groin pain. It's been going on 3 months. I'm not sure how I got hurt. No trauma, no whatever. Diagnosis as groin strain. We do the subjective exam. It's kind of painful. It's kind of not. It's just doesn't feel real good. But it does say, I got this feeling of fullness in my proximal thigh. So we do an objective exam. Range of motion, manual muscle test look fine. Palpate a little bit, we just kind of feel this kind of boggy, kind of liquidy mass in the anterior thigh. Trigger points were fine, but we do see he's got some redness and bruising around that area. So really what I want you to kind of think about is which one of those differential diagnoses, which one of those diagnoses matches with that? Is it a muscle strain? Is it something oncologic? Is it a AAA? Is it appendicitis, right? Is it avascular necrosis? Probably not, right? Probably what we're dealing with is something else, right? Because we don't have any clear objective findings either. So here's what we got. We got a big old hematoma that we see on an MRI in the anterior thigh. Now, what we need to kind of dig into, and this is kind of outside the scope of practice of physical therapists, why the hematoma is there, right? Because if I don't have some sort of trauma, I need to know why I have this huge dinosaur egg in my thigh, right? That's kind of a problem. So this person would be referred out, and they would do all sorts of testing on this site. When it comes to bone stress injuries, really watch out for bone stress injuries, okay? Especially with our long distance runners. What I will tell you is watch out for our new distance runners, whether that is adult, somebody that's looking to get in shape, looking to train for a marathon, and all of a sudden there's a rapid increase in training miles and training time. Also watch out for our adolescent runners, right? Because adolescents have a couple things working for them and working against them. They have a growth pattern, right, and a growth spurt, if you will, that is unrivaled in the human life cycle outside of being a fetus, right? So if bones growing and muscles growing all over the place and growing really, really wildly, and then we're putting in this other variable of high impact stress via running and a lot of reps over a lot of time. So that kind of not necessarily leads for a recipe for disaster, but definitely can increase the risk profile for a bone stress injury. What we want to do when we suspect a bone stress injury is we want to go straight to the MRI. And I'm going to show you exactly why we want to go straight to the MRI. X-ray is not going to show you a whole lot here. And in fact, a lot of bone stress injuries on X-ray get missed. So there is a 4-grade system on how the periosteum looks via MRI. That goes from the lowest being a mild to moderate edema on a T2 MRI, all the way up to a grade 4, which is severe edema. This is another really good case, right? So this was written up in JOSPT a few years ago. Take a look at the left-hand side, right? And in fact, I think if I took the arrow away, you might not see the fracture to the femoral neck. You might see it, you might not, right? But it doesn't look like it's real definitive. However, put that on MRI, and obviously we can see a considerable difference from right side to left side. So this is another really good indication why we need to use MRI for bone stress injuries. This is a femoral neck stress fracture and femoroacetabular impingement, quote unquote FAI. So another good case why we're going to use MRI for a lot of these cases. X-ray is probably not going to show that, but that's going to show up on MRI pretty quick. This is an interesting one because this is an insufficiency fracture of the pubic rami. Now, what's really interesting about pubic rami, just like what we saw in the pelvic ring, pubic rami typically is going to have multiple fracture sites, right? So that ring is going to rupture or fail at multiple locations. So really interesting, quick, easy test that you can do, especially when it comes to femoral shaft stress injuries. Now remember, femoral shaft stress injuries, femoral shaft stress injuries are pretty rare, right? So we're not going to see these a whole bunch. This is going to be one of those, as we call it, like the once in a career one, right? What we're going to see though is antalgic gait with these folks, not able to do a single leg hop without a bunch of pain. And then what the picture is demonstrating in the lower left-hand side of the screen is something called the fulcrum test. And what the fulcrum test is going to do is just going to provide an area of stress. Literally, the femur is going to get bent over the fulcrum of the provider's forearm. And this can be a really good test to rule out, quote unquote, screen for a femoral shaft stress injury. So when it comes to bone stress injuries, these are the big signs and symptoms. Remember, associated signs and symptoms is where it is. That's what it's all about. If I have a deep aching pain, if it's getting worse with activity, worse with weight bearing, I better start thinking something bone. If I ask what the easing causes or easing motions or positions are, well, I got to lay down, right? And I just, every time I get my leg up or every time I take weight off my leg, I feel perfectly fine. Well, that's a pretty big indication something's going on. If there's associated with change in activity, so in other words, hey, I just started running, I just started doing all this weightlifting, I just started conditioning for football, whatever it is, there can be potential for a bone stress injury. Big objective findings we're going to have, they can have a positive heel strike test, single leg hop test is a big one, fulcrum test is another big one. So another case here. So what we got is we got a 19-year-old male marathon runner. His thigh's been hurting for about 9 days. His ags, like what hurts him, is basically only running. That's it. He has some mild vague discomfort with resisted knee extension. Fulcrum test was negative. He came in with the diagnosis of quad strain. So we went ahead and treated him, re-evaluated him a couple weeks later. Everything's worse. And he has a positive fulcrum test now. So more than likely, this person has some sort of bone stress injury. Now remember, in this case, we're not necessarily going to be able to make that diagnosis. We're going to need an image to confirm that diagnosis. So what can we say? We can say, hey, PT is not working, right? Because we've seen him for 2 weeks. His thigh pain's worse, right? So I think we can safely say PT is not working. We also can say this person now has a fulcrum test that's positive. That's highly correlated with a bone stress injury. Can we get this person an MRI? There's the x-ray. What you can see is the periosteal layer is just a little bit raised. But then we put them in an MRI, and that thing lights up pretty good. So honestly, what we had here was a bone stress injury. But like I said, sometimes it'll come in as a diagnosis of a quad strain. Here's another case. Okay, so this is basically the same sort of presentation. What we can see too is not necessarily just in runners, but in folks that are increasing their activity level a bunch. One population that we see this in is actually, it's really interesting, and I'll try to look up the video for you guys, is there was a drastic increase in the military of hip bone stress injuries. And big reasons were that there were a lot of recruits that just weren't used to that sort of physical activity. So they had a huge problem with bone stress injuries, and I'll see if I can pull up that video for you. So systemic causes of sciatica, radiculopathy versus neuropathy. You guys go over a lot of this stuff in MSK. I'm not going to belabor this point a whole bunch. Just understand what sciatica looks like, understand what the clinical practice patterns are. So when it comes to the lower quadrant, if my patient's having bone pain and they're younger than 20 or older than 50, I need to get a little concerned. We could have something like cancer recurrence. We could have something like Hodgkin's disease or a spinal cord tumor or a bone tumor. Remember, associated signs and symptoms is where it's at. If that person has associated signs and symptoms, aka they have some red flag stuff going on, then we need to get that person out of our office and seeing another individual. So here's another case. We've got a 30-year-old comes in with left buttock pain. He's referred to ortho with a diagnosis of ischial-bursitis. So we take a look at him. He's got intermittent left buttock pain, gets worse with sitting. What's his ease? Well, if he unloads his left side, Okay, that still could be ischial bursitis. Previous treatment, they did some steroid injections with him, did some NSAIDs, and the MRI said, yeah, he's got some inflammation at the ischial tuberosity. All that so far matches up with ischial bursitis. So far, in terms of what's next, we can probably go ahead and see this person. Now, what we do is we do a bunch of deep friction massage, we do some ionto, we do some stretching, we do some modification of chairs, we do some, we do a whole bunch of stuff. We see this person around 10 times over about an 8-week period of time, and he's getting worse. So now what do we do? Now we have a lot more information. We've provided a decent amount of treatment to this person, and they're doing nothing but getting worse. Obviously, my first question would be, if we're not making them better, why are we still seeing them? And we probably need to refer this person out. So they went in, they referred him back to ortho. Hey, we're not doing anything. Can you get a second MRI or can you do something else for him? Sure, no problem. They repeat the MRI, they repeat the injection, send him back to PT. He's doing a lot better. PT does the same stuff for another 10 visits over 6 to 8 weeks. He's getting worse again. Send him right back to ortho. So ortho goes in and they do a bursectomy. They take out the ischial bursa. When they take it out, they realize, oh, there's a huge sarcoma in there as well. And the person required a second surgery. But in terms of red flags, the big red flag was the person wasn't getting any better with therapy. Now, you can make a case that they went in, did another injection, sent them back, and, let's give PT another try. But PT wasn't making this person any better. Remember, that is a category 3 red flag. So when it comes to urogenital causes of pain, we obviously want to first think kidneys, and then the path from the kidneys down to your urethra. So ureters, bladder, things like that. Also watch out for testicular pain and prostate pain as well in males. Associated signs and symptoms, remember that's going to be the big thing that we see here. So when it comes to infection and inflammatory causes, if we have a joint pain of unknown origin, that's a problem, right? We could have rashes. That's a pretty good sign or symptom that this person may have some inflammation going on or infection going on, especially. If there's fever, remember fever is a huge indicator of infection. We could have a psoas abscess like we talked about earlier, right? That may refer to buttock, hip, groin, thigh, knee. We could have some abdominal pain. If that person has a hip flexor contracture or a spasm, remember they also can maybe sometimes have that feeling of fullness. If they have positive psoas signs, positive psoas obturator test, and like I said, fever, night sweats, that's going to be a big one for infection. When it comes to vascular causes, typically, like we said earlier, if it's vascular in nature, it's probably going to throb. Why? Because that's what the vascular system does, right? It pulses blood all over the body. Therefore, it's going to give a throbbing sensation. So typically, it's in an older patient that we'll see this in. Sometimes a history of cardiovascular disease, but I'll tell you, not always. And then peripheral vascular disease or peripheral artery disease, intermittent claudication and burning and cramping is going to be a big one here. Now think about that bicycle test, right? So we put folks on the bicycle. Do they have neurogenic claudication? Do they have cardiovascular or vascular claudication? And we might need to do that bicycle test to kind of rule out or tease out which one of those causes it actually is. Abdominal aortic aneurysms can refer to the hip as well. Mostly these are going to be like a sudden groin pain, right? So if you think about it, if the abdominal aorta has an aneurysm in it, and I'm not getting blood down to one of my common or external or internal iliac arteries, then I'm going to have pain probably in the pelvis, maybe in the groin as well. So here's another case. We've got a 41-year-old female, bilateral weakness, bilateral numbness, buttock, SI joint pain, referred to primary care for bilateral sciatica. So we do the subjective, and she has cardiovascular disease. Been smoking for about 26 years, which is not uncommon. Some folks get smoking pretty early. Atraumatic onset around 2 months, right? So not really sure why she's had pain, right? It just kind of happened. That should be a huge red flag in itself. Aggravates, walking about half a block. If I get off my feet, it really, really helps. No night pain, no weight loss, no fever, not short of breath, anything like that. So think about what this could be. This could be a lot of different things. This could be because we have a history of cardiovascular disease. So first thing I'm thinking about is probably something cardiovascular, right? Especially since we have a history of cardiovascular disease and current smoker and no trauma. So we check her out. Everything, neural tension looks good. Neural screen looks good. Lumbar spine looks perfectly fine. What we see though is we check out dorsalis pedis pulse, and that's diminished. Now we do the bicycle test with her, put her in a flex position, and legs get weaker, and the dorsalis pedis pulse is gone. It's completely eliminated in the left lower extremity. Right lower extremity, no big deal. That's a huge deal. That's a huge sign, right? Because what we've ruled out is this is not neuro. We've put her on this bicycle test, and we've kind of ruled out that when that vascular system in the lower extremity is called upon, it's not able to respond. It's not able to do what it's supposed to do. That's a huge sign that this person has something vascular in nature happening. So when it comes to osteoporosis and tubercular disease, we can see these. I'm not going to say super often, but definitely be careful with it. Be careful with folks that don't have those diagnoses, because they may have the active pathology happening, and either they haven't been to the doc or something else has happened, and they just don't have the definitive diagnosis. So just be really careful with folks. What we want to do is, if we have painless lymph node enlargement, okay, so we start palpating lymph nodes, holy cow, those lymph nodes are really big, send them out. Especially if they have a history of cancer, send them out. If they have a hip or groin pain that's associated with abdominal pain, send them out. If they have an exam consistent with the femoral neck stress injury, right, send them out. And especially if they have signs and symptoms of cauda equina, definitely send them out. Please, please do. Routine medical attention, meaning not a immediate emergent referral. If their pain in their hip is getting worse after a total hip replacement, there's probably something wrong with the total hip replacement, right? They should not have progressively worsening pain. If they have progressive neuro findings, now what do I mean by that? If their reflexes are 2+ on the eval, and then you re-eval them in 4 weeks and they're 1+, and then maybe you re-eval them 2 weeks later and they're 0, that's a progressive neuro finding, right? Or they're progressively getting a cold leg, numb leg, progressively getting, they're getting worse. That's a sign that we really do need to send them out. And if there's some sort of atraumatic joint pain with a history of Crohn's disease, we probably want to send them out because they could be having a flare-up of Crohn's. All right, so getting into a little bit of imaging here. Honestly, if you guys want to take a break, even though this is a kind of a podcasted recorded lecture, I perfectly understand. Hit the pause button and take as much rest as you need. So straight out of Riemann's textbook, what we see here is diagnostic accuracy of various imaging modalities, right? So big things to look out for here. Labral tears, we're not going to go x-ray. In fact, we're going to go CT, MRI, MRA, especially MRA, just like we saw in the shoulder. Those are pretty specific, pretty sensitive, right? Those are pretty good tests. X-ray is probably not going to show you a labral tear, especially with the acetabulum shaped the way it is. Articular cartilage lesions, same thing. We want to go MRA, MRI. Those are not fantastic, as you can see from the numbers, but unfortunately, I think those are about the best we got. Impingements, again, we want to go MRA, MRI. Like I said, not really going to show up on an X-ray or radiograph. And things like femoral stress fractures, bone scan is probably going to be your number one. MRI, as you can see, 100% sensitivity, 100% specificity. It's rare that you guys see that. So MRI is going to be a really good one as well. So when we look at an AP hip projection, this is essentially what we're going to see, right? So we can see several different anatomic structures and anatomic landmarks via radiograph. So number one is going to be that superior acetabulum. Number two is going to be the femoral head. 3 is going to be the femoral neck. 4 is going to be the greater trochanter. And 5 is going to be the lesser trochanter. When it comes to, quote, the frog leg hip projection, what's happening here is the patient's placed in a little bit of external rotation, a little bit of abduction. And as you can see, what it does is it gives you a much different appreciation for the hip. So what we're going to see here is number 1 is the iliac crest. Number 2 is going to be the ala, or the wing of the ilium. Number 3 is going to be your sacrum. 4 is going to be that SI joint. 5 is going to be the acetabulum. 6 is going to be your superior pubic ramus. 7 is going to be the inferior pubic ramus. 8 is the pubic symphysis. 9 is that ischial ramus. Number 10 is going to be the femoral head. So that femoral head is going to kind of hide behind the acetabulum a little bit. And 11 is going to be the femoral neck. 12 is going to be the greater trochanter. And 13 will be the lesser trochanter. So routine radiographic views that we're going to see, typically we're going to see an AP, typically we're going to see a frog leg lateral. Very rarely you're going to do a lateral, and that's simply going to be just based on positioning what you're actually going to see. So AP hip projection, this is how it is made. The big thing to remember here is legs are extended and internally rotated 15 to 20 degrees. What that does is that places the femoral necks parallel to the image plane, aka I can see them better. So when I place that patient in the standard X-ray machine, I need to internally rotate their femurs about 15 to 20 degrees. There's a lot of things we can see in the AP projection. What we can see is we can see that femoral head, neck, greater trochanter. We can see the femoral shaft and the proximal 1/3 of it, and possibly see the lesser trochanter. These are all the structures we can see. So obviously you can see a lot of stuff here. What I want you to kind of think about is how each of those would look if they get fractured or something else happens to them, if there's an avulsion fracture, something like that. So when it comes to frog leg hip projection, this is exactly how it's made. So patients placed in a little bit of external rotation and abduction. And we're just going to get a little different look here, right? So we're going to get a little different view. So this is essentially what a frog leg is going to look like. As you can see, I get a much different view of the femoral neck, much different view of the femoral head. That's everything we're going to see on a frog leg projection. So when it comes to axiolateral hip projection, just understand how this image is made. Understand that we're essentially having the patient's contralateral unaffected side flexed in terms of the hip, and we're shooting in that image at the other side, right? So the imaged side is placed in neutral, but the other thigh is placed up in flexion so we can see through to the medial side. Gives you a little different view, right? So I can see the acetabulum, I can see the femoral head, I can see the femoral neck, and I can see the trochanters. So here's the axiolateral hip projection. Like I said, you're just going to get a little different view, right? So why are we going to use something like this? We're going to use something like this because we suspect maybe that person has a lesser trochanteric fracture and we need to see fracture line direction, or we're not quite sure where exactly that femoral neck fracture is. It could be somewhere else other than where we originally saw it. So when it comes to hip fractures, remember that we're going to have intracapsular fractures and we're going to have extracapsular fractures. So intracapsular fractures are going to be really, really important and really, really dangerous for our patients because they're going to tear the circumflex femoral arteries. Remember those from anatomy. They're going to include avascular necrosis as a complication. That's going to be a big one. And typically what they're going to do is they're going to screw it together. An extracapsular fracture basically comprises about 50% of all proximal femur fractures, right? So extracapsular are pretty important as well. And typically they're going to repair that with a little different repair, right? So they're just going to use an angled plate. So when it comes to hip fractures, about 90% of fractures are femoral neck or intertrochanteric. In fact, you're going to see a lot of these. Typically what we're going to see with the femoral neck fracture, big reason is osteoporosis. And on the x-ray, the stress fracture of the femoral neck may seem sclerotic, right? So remember what sclerosis is. Sclerosis typically is a whitening or brightening on that x-ray. So what we could see is that we have a whitening or brightening, but no extra fracture line. So we could have a stress fracture happening there. The intertrochanteric region is typically due to trauma. Typically what we're going to see is a shortened leg that's internally rotated. And the big point that I want to make also is if it's a non-displaced hip fracture, they're ridiculously hard to see on x-ray. They're very tough. Put the patient in an MRI and just go ahead and get a definitive answer. That is a very bad femoral neck fracture, right? So that is a bad femoral neck fracture that it is non-displaced, but there's a pretty significant line there. That is an intertrochanteric hip fracture. What you can see here is a fracture line literally just kind of spans across and in between both of the trochanters. When it comes to non-traumatic hip joint imaging considerations, watch out for joint spaces and pelvic lines. Presence of bone disease like Legg-Calve-Perthes Disease or cysts or tumors is a big thing. The shape of the femoral head is very important. And the presence of osteophytes or arthritis is also very important. So when it comes to hip osteoarthritis, this is the most common cause of hip pain, and especially chronic hip pain. So if your patient comes in, hey, I've had pain for 3, 4, 5 months, I've had pain for a couple years, whatever it is, start thinking osteoarthritis. It may become something else, but your safest bet is going to be osteoarthritis. So typically the patient is going to present with pain and loss of mobility. Typically, internal rotation will be the first one to go. Now, also realize that about 90% of patients over 40 are going to have some hip degeneration happening. So the reason I say this is because obviously folks 40 years old and over are going to go in, have an x-ray done, hey, my hip's kind of hurting. It's going to show some arthritic changes. That does not necessarily mean that the arthritis is causing their pain, right? So that image has to map up with clinical signs and symptoms as well. So what we're going to see with hip osteoarthritis in terms of findings, typically the joint space is asymmetrical and it's narrowed. There is a sclerotic subchondral bone. Osteophytes are typically at the joint margins. Cysts or pseudocyst formation can happen. And we might actually see the femoral head migrate or move out of its original position. So what we're going to see here in this x-ray, in this radiograph, You have evidence here of some sclerosis, right? That brightening on the radiograph. You can see the joint space between the femoral head and the acetabulum. This is almost what we would call bone on bone, but not quite. There's a little bit of a line there showing some separation, but definitely narrowed. And then there's a huge osteophyte as well. What we see here, and this is a more severe one, is we see some subchondral cysts, we see osteophytes and irregular borders, and we see some joint space narrowing as well. Now, rheumatoid arthritis is a different animal. That's a different beast. What we're typically going to see with rheumatoid arthritis is osteoporosis in the periarticular area. We're going to see some joint space narrowing. We're going to see erosions, effusion, and sometimes what we'll see is acetabular protrusion. Okay, so remember with osteoarthritis, we had femoral head migration. With rheumatoid arthritis, we're going to see acetabular protrusion. We'll also see some migration of the femoral head as well. And that's just because of the morphology of the joint. So this is what rheumatoid arthritis looks like. Radiograph up in the upper left-hand corner of the screen. Obviously, postoperatively in the lower right-hand corner, we see a much different picture, right? So they went ahead and did a joint replacement on the person, and we see pretty good alignment there. Femoral neck stress fractures, these can happen a lot. We kind of covered these already in the medical screening portion, but we're going to cover a couple MRIs and a couple more x-rays of it. So this is a pretty bad one. Okay, so this is a stress fracture that has become a complete fracture. You can definitely see it on a radiograph. Remember that for a lot of these fractures, they're not going to be as definitive as this, and an MRI is going to be best. This is another stress fracture as well. This is another pretty severe one. This one's not as severe as the last one, but definitely you can see that there's some buckling or there's some compression right at that femoral neck. This one you can't see so much, right? So this one, if you're just looking at it and looking at it quickly, you might miss this one. But once you really hone in, you can see that there is some compression right around the femoral neck. Take a look at that. And I'm going to take away that again. That's your stress fracture. That's why these get missed so much, right? You can barely see it. Now put that person under a bone scan, and obviously what we can see is we can see a huge bright spot happening right at that femoral neck, which then gives us really good evidence that there's an active pathology happening right there. So this is a femoral stress neck fracture on X-ray. There again, there's our fracture right there. On MRI, looks pretty clear. And then another MRI. So when it comes to avascular necrosis, like I said, we already kind of covered this in the medical screening section. But typically what you're going to see is you're going to see the external vessel compression. You're going to see a thickening of vessel walls and thrombolytic processes, right? So that's typically what's going to cause avascular necrosis. Remember, the avascular necrosis can be progressive, right? So what we can have is we can have radiographs that appear normal for a long time. Then we have bone scans that identify some increased uptake after injury. MRI is going to be our best bet. Early MRI, and it's going to be the most sensitive and most specific. What we're going to see on radiograph findings is we're going to see something called a crescent sign. And what that crescent sign is that there's going to be a little area of darkness that forms in the shape of a crescent right around that femoral head. We're going to see some osteoporosis, which makes sense, right? If the bone's not getting enough blood supply, it's going to start dying off. Sometimes we'll see some sclerosis as well. We'll see some thickening around that site. There might be some cystic changes. Flattening of the head is a big one at the for avascular necrosis. So if we see that the femoral head is not round anymore and it's got kind of a flat top to it, then that's pretty good evidence that avascular necrosis is happening. That's what flattening of the femoral head looks like. Just give you a line of reference. That's exactly what flattening looks like, right? So we don't see that really nice round femoral head anymore, but it looks like that femoral head has kind of lost its roundness. This is what avascular necrosis looks like in MRI. Obviously, you can see it a lot better than you can on X-ray. So avascular necrosis, what we want to kind of bring home as a point, MRI is going to be your best bet. When it comes to Legg-Calve-Perthes disease, we can see some osteonecrosis of the capital femoral epiphysis. And typically what we're going to see is 4 phases, right? So what we're going to see first is some effusion, a wide joint space, demineralization around the epiphyseal lines or plates, increased density in the femoral head, radiotranslucent areas around the epiphysis, deformity or flattening of the femoral head and widening of the femoral neck. And typically, males, typically around 6 years old. These are going to be little kids that get this. This is typically what it's going to look like. As you can see, both of those epiphyseal plates look like they've been absolutely demolished. This is what a slip capital epiphysis looks like on X-ray. We kind of covered this a little bit earlier, but this is exactly what it's going to look like on X-ray. What we're going to see is sometimes you'll see epiphyseal widening, and sometimes you'll actually see the entire femoral shaft and femoral neck displaced to where from what's originally supposed to be. There's a labral tear on an MRI. So what I want you to take a look at is that very, very small section. Let me go back. A very small section where you can see labral tear happening. Look at there at the top. And they're not going to be very, very apparent. But what we have to understand is we have to understand that sometimes these labral tears are very hard to find and therefore get missed sometimes in diagnosis. There's an adductor tear on an MRI as well. So that's what an adductor tear is going to look like. And then kind of the last concept I want to cover here is femoroacetabular impingement. So there's several types of femoroacetabular impingement. I'm not going to go into it too far because I know you guys go into it in other course content. That's what a cam impingement looks like. That's what a pincer impingement looks like. So pincer impingement, that acetabulum is going to come out like a couple claws or a couple pincers, and that's going to kind of hug around, for lack of a better term, around the femoral head. So femoroacetabular impingement, it actually happens quite a bit in athletes. So what we have seen is 33% of the subjects that have FAI consider themselves athletic, right? So there's quite a bit of these. All right, thank you guys very much. I appreciate the time. Other than that, have a very good day and a very good week.